Welcome to ACSM's Brown Bag in Science webinar. May was Exercise is Medicine Month, so we are pleased to finish out the month with a webinar focused on exercise as medicine. Today, Dr. Sarah Linke will be our presenter. She is going to give a 25 to 30-minute presentation, and we'll have time afterwards for question and answers. Sarah is a licensed clinical psychologist who serves as an associate clinical professor in the Department of Family Medicine and Public Health at UC San Diego. Her position includes behavioral medicine research, direct patient care as a clinical psychologist in UC San Diego's primary care integrated behavioral health program, and she also teaches in the undergrad public health program. She's a busy lady. Sarah's broad research area is in health promotion and behavior change with a focus on exercise and physical activity. She currently has a 5-year career development award to combine implementation science and quality improvement methodologies to implement and evaluate the Exercise as Medicine initiative within the UC San Diego health system. She will be sharing more information today about that particular project. With that, I'll turn it over to Sarah for her presentation.
Thank you for the kind introduction, Lynette, and thank you for inviting me to speak today. I'm very excited for the opportunity to share with all of you details about the Exercise as Medicine Implementation and Evaluation Initiative that I've been working on at UC San Diego Health. I would first like to acknowledge the funding that has made this project possible. I've been working on it for the past 3 years, starting with a pilot that was funded by 2 internal grants. I'm currently 1 year into my 5-year career development award from the Agency for Healthcare Research and Quality, so stay tuned for more to come in the next 4 years. Like most research, it's been a slow and sometimes arduous process, but overall it has been extremely rewarding to see the impact it has had on primary care, and most of all, the teamwork involved among the numerous people. I want to thank all of the individuals and groups listed here for their hard work and collaboration on this project. I also want to give a special thanks to ACSM and the EIM Governance Board, Advisory Board, and subcommittees for their support. I also want to thank Dr. Bob Salas for creating such an important initiative 13 years ago and for tirelessly working to expand its reach. Here's an overview of my presentation today. I'll spend most of the time talking about the second item on the agenda, but let's start with a brief overview of what EIM actually is. This is one of my favorite quotes. If exercise could be purchased in a pill, it would be the single most widely prescribed and beneficial medicine in the nation. Most people would agree with this statement. So the question is, why is exercise not routinely prescribed? Despite evidence supporting the cost effectiveness of brief exercise counseling in primary care, only 1/3 of patients report receiving exercise counseling from their PCPs. Key reasons for this include a perceived lack of the training and time required to provide effective exercise counseling. What if a simple formula existed for exercise to be prescribed efficiently and effectively in primary care? Would physicians use it? We can now investigate that question by implementing and evaluating the Exercise as Medicine program. Supported by ACSM, EIM was founded in 2007 and has since grown into a global initiative that has so far been adopted by healthcare systems in more than 50 countries. The prescription starts with the physical activity vital sign, or PAVS. Responses to these 2 questions are multiplied together to determine whether or not a patient is completing the recommended 150 minutes of moderate intensity physical activity per week. Much like other vital signs that are routinely measured and recorded at primary care visits, the PAVS is ideally administered at every visit so that trends in physical activity levels can be monitored over time. Providers are encouraged to address exercise at every visit to acknowledge the importance of it, even if it is just to encourage patients to keep up the good work. But discussing physical activity with patients who are not meeting guidelines is especially important since research shows that even very brief counseling can make a difference. To reinforce that discussion, patients are given a written prescription to gradually increase their physical activity levels until they are meeting the guidelines of 150 minutes per week of moderate activity. Whenever possible, insufficiently active patients also receive a referral to additional exercise counseling and other resources to help them develop physical activity goals and identify potential barriers and solutions to meeting them. Now that we're all on the same page about what EIM is, I'm going to talk about how I'm implementing and evaluating it within the UC San Diego health system. These are the 3 specific aims of my project, which correspond to 3 distinct but overlapping stages of the project. In the next few slides, I'll break down each aim and discuss the 2 health services research frameworks I'm using to accomplish these goals. This study innovatively uses a combination of implementation science and quality improvement strategies to advance the EIM initiative. It is an uncontrolled design with replications across 6 clinics that allow multiple PDSA cycles to develop optimal implementation strategies at each clinic. The first model I am using is an implementation science model called PRISM. The practical, robust implementation and sustainability model evaluates how a healthcare program interacts with its recipients to influence the well-known RE-AIM outcomes: reach, effectiveness, adoption, implementation, and maintenance. The second model I'm using is a quality improvement model called the learning evaluation model. It's a methodological approach that blends quality improvement and implementation research methods to study healthcare innovations. It focuses on continuous quality improvement via rapid plan, do, study, act, or PDSA cycles. This very busy figure depicts how the 2 models fit together in the context of this study. The top portion includes the pre-implementation and program evaluation components that comprise PRISM. The bottom portion includes the learning evaluation model's continuous quality improvement cycles. In the next few slides, I will break down this complex diagram. In phase 1, we used PRISM to guide a comprehensive pre-implementation evaluation and adaptation of EIM protocols, materials, and delivery strategies to ensure that they fit within the existing workflow at the first clinic. This included input from providers, staff, and patients, as well as information about the external environment and existing infrastructure. For example, I first co-designed the EIM workflow with Dr. Kallenberg, who is the Family Medicine Division Chief and Medical Director of our pilot clinic. We worked with a programmer to build and test the key features in the EMR and asked a handful of providers to do the same. We then enlisted a physician champion to promote EIM and train clinic staff and providers to deliver the adapted EIM protocol. This table contains examples of questions that we asked clinic and healthcare leaders, providers, and patients to obtain their input about EIM during the pre-implementation phase. For example, we asked clinic and healthcare leaders to weigh in on whether or not EIM would be a feasible initiative considering competing demands on primary care. Overall, they believed that creating an efficient process that aligned with existing clinic workflows and could potentially help to save providers time by providing resources and health coaching for exercise support would be a wise investment worth implementing. We also asked providers to share their ideas about how to increase the efficiency of the EIM workflow. One provider suggested that we add 1 question to the PAVs asking patients if they would like to speak with a health coach about exercise and incorporate an automated referral system to the health coaching team if they say yes. Prior to that modification, our workflow relied upon PCPs and nurses to proactively ask patients if they would like a health coaching referral and then manually make those referrals in Epic. Although the original workflow was designed to align with the process we have in place to refer patients to our integrated behavioral health program, it was clunky and underutilized. The revised process, based on the provider's input, resulted in a marked increase in referrals to health coaching. Finally, we also gathered patient input on the physical activity manual we created for EIM. In addition to asking for feedback on the content of the manual, we also asked them if they would prefer to receive a physical copy of the manual and/or an online version of it. They overwhelmingly voiced that they would prefer to have access to both. Given the cost of printing these manuals at $8 each, the patients stated that they would be happy to have access to a copy in the primary care office to peruse and could then access the online version at home to spend more time with it. We carefully considered and addressed all of these and other valuable ideas and concerns when designing and refining our protocols and materials. For phase 2, we are currently using the learning evaluation model to iteratively pilot, refine, and implement EIM within each of 6 primary care clinics using rapid 3-month PDSA microcycles, followed by learning meetings to gather feedback and generate ideas for improvement to optimize workflow. We are systematically tracking modifications and adaptations throughout its implementation at each clinic. Ideas generated during the multiple iterations of this refinement process have ultimately improved the design and resulted in a smoother workflow and higher percentage of visits with EIM. This is the overview of the current EIM workflow. It includes 3 main branches, which I will describe in the next few slides. Because of the built-in automation of the EMR system, the entire workflow depends on the first 2 steps. The first branch depicts the automatic systems that are triggered when PAVS data is recorded in the EMR. The diagnosis of inadequate or adequate exercise is automatically saved in the patient's visit diagnoses and problem list, and a tailored prescription is automatically generated and printed in the patient's after visit summary, or AVS. Because each clinic has its own workflow, how the PAVS is recorded in the EMR varies to an extent. For example, patients at some clinics use pen and paper to complete intake questionnaires, which are then recorded in their charts by the MA who rooms them. Other clinics rely on the MA to ask intake questions aloud and record them in the EMR during the rooming process. Some clinics use an e-check-in system that enables patients to complete their questionnaires online in a portal that feeds directly into their chart. Until very recently, the MA still had to click an accept button for that data to be saved. A unique feature of this project is that it contains a natural experiment evaluating how these different methods are related to the rates of PAVS data capture, which we will examine later in the presentation. This is an example prescription that a patient receives in their AVS if they completed the PAVS. If a patient is already meeting guidelines, their prescription will encourage them to maintain their current levels of activity. We modified the prescriptions to also include links to the COVID-19 EIM resource page that ACSM created, as well as to the San Diego Health Department website to help enable patients to exercise safely and lawfully during the COVID-19 pandemic. To help reduce the burden on providers, we created a comprehensive physical activity manual for patients to refer to for information, resources, tips, and local places to be active. We conducted 2 patient focus groups to obtain feedback on the manual from a patient perspective. We then revised the manual based on that feedback and edited the revised version before printing it to place in the clinics and posting it online. We repeated this process with the Spanish translation of the manual. The ACSM COVID-19 resource page now serves as a complement to this manual. The second branch of the workflow covers the PCP's portion of EIM, which includes a brief patient discussion and standardized EMR documentation. As mentioned previously, if PAVS data is entered into the EMR, the patient automatically receives a diagnosis of adequate or inadequate physical activity. An orange banner reminder then pops up on the PCP's screen, prompting them to discuss exercise with their patient and document that discussion using the .EIM smart phrase that makes this process efficient and simple to evaluate. Providers use their discretion to determine whether or not a discussion about exercise is appropriate given time constraints and the reason for the visit. They can select the appropriate option within the smart phrase to accurately document their decision. Finally, the third branch of the workflow covers the health coaching portion of EIM. As shown earlier on the PAVS form, patients also have the option to self-refer to receive a free 15-minute health coaching phone call. They are then placed on a waitlist and receive a call within approximately 2 weeks. These screenshots depict the smart phrases programmed into the EMR to reduce the documentation burden on the health coaches, freeing them up to spend their time speaking with patients. They can choose from a selection of smart phrases depending on the patient's current exercise stage of change. They then route the note to the PCP to retain continuity and notify the PCP of any relevant issues, such as a patient requesting a referral to physical therapy or another healthcare service. In phase 3, we are using the re-aim outcomes, which are embedded within PRISM, to guide a comprehensive program evaluation to help determine the program's acceptability and potential for successful long-term sustainability within the UC San Diego health system. This phase is still a work in progress, but I'll present some preliminary data on the next few slides. This map of San Diego County gives you an idea of the region served by this project. As you may notice, most are located in the coastal region. However, patients come from all parts of the county to receive care at UC San Diego Health. The main purpose of reviewing these next few slides in detail is to demonstrate how continuous monitoring of EIM data has enabled us to identify and resolve issues. This table reports data from the pilot clinic, which we launched in October 2018. I realize that it contains quite a bit of information that may be difficult to see, so I'll draw your attention to a few of the most noteworthy data points. First, we can see a downward trend in the percentage of patient visits with PAVS data in the first few months of 2019, with the percentage of providers documenting EIM following suit. We initially thought that this might have just been due to simple growing pains, but as the rates plunged further, we decided to investigate. We eventually figured out that glitches in Epic were resulting in the failure of intake questionnaires to print upon patient check-in. Only patients who completed their questionnaires via e-check-in or had a very diligent MA asking them questions aloud completed the PAVS during this time period. You can see how after that issue was resolved, the data trended upward again. Next, we can see how PAVS rates dropped again this March and then not only recovered, but exceeded previous rates in April. As you might suspect, this was related to the rapid transition to telehealth due to COVID-19. After noticing the low rates of PAVS and other intake questionnaires, we learned that e-check-in questionnaires had not been transitioned over to telehealth visits in some primary care clinics, including this clinic. Perhaps most interesting of all of these trends is the increase in April to unprecedented levels. You will see the same trend in the other clinics in the next few slides. We can probably attribute this improvement to the major reduction in human error since most patients are now using e-check-in. We expect to see even higher rates in May since we eliminated the extra step previously required of the MA to accept to save that data in the patient's chart. Unfortunately, we have also seen a drop in PCP documentation of EIM during this time, so we are currently looking into the root cause of this problem. In the percent problemless column, we can see the steadily increasing rate of patients with the diagnosis of either adequate or inadequate exercise listed in their chart. Now that EIM has been in place for 1.5 years at this clinic, we see that approximately 85% of patients who have had a PCP visit during this time have completed at least one PAVS questionnaire. Finally, we can see a significant increase in the percentage of patients who have self-referred to exercise health coaching in the past few months. Due to a change in the referral process, we are only counting data since June 2019 in this column. We attribute this increase to the automated process that was implemented last fall to replace the old system that required a manual referral from the PCP. We see similar trends in the second clinic that was launched in October 2019. First, we can see an expected steady increase in the percentage of visits with PAVS completed in the first 3 months. We also see the same sharp rise in the percentage of PAVS completed in the past month, with mostly telehealth visits completed and a corresponding rise in the percentage of patients who self-referred to health coaching. We see the steady increase in the percentage of patients with an exercise-related diagnosis on their problem list. And finally, in this clinic, we see a smaller percentage of physicians documenting EIM across the board. This slide contains data from clinics 3 and 4. On this slide, I primarily want to draw your attention to the percentage of PAVS completed in the first few months of clinic 3. This particular clinic has been the only one we have launched so far that has historically used the approach of the MA asking the intake questions aloud with the patient and recording them in the EMR during the rooming process. As you can see, the rates of completed PAVS were extremely low in the first few months relative to the other clinics. I received feedback from the providers that asking these questions aloud was adding a significant amount of time to the already lengthy rooming process, which is understandable considering that patients often like to chat about their exercise. As you can see, when this clinic shifted to primarily telehealth visits due to COVID-19, their rates of completion started to look more like the other clinics. Finally, the fourth clinic just launched in April, and so far the data suggests that uptake has been relatively high for a kickoff month, particularly with regard to the health coaching referrals. We actually launched Clinic 4 by request of the clinic's medical director because providers were receiving numerous questions from patients about how to exercise safely during this stressful time. In addition to evaluating EMR data, we also recently collected the first round of patient feedback and satisfaction with EIM. A brief 10-item survey was sent via my chart to all patients with a non-acute PCP visit during a 1-month period from mid-February to mid-March. Approximately 25% of these patients completed this survey, resulting in a sample size of 316. My MPH student collected this patient data for her master's thesis primarily to compare rates of documented PAVS, exercise discussion by providers using the .EIM smart phrase, and referrals to health coaching in the EMR versus patient-reported data on the same variables. This would indicate whether or not the EIM components are sticking with patients and provide markers of validity and reliability. The patient-reported data align very well with the PAVS and health coaching referral data, as you may recall from the previous slides. Interestingly, however, 73% of patients reported that physical activity was addressed at their visit, including approximately 2/3 who reported that their PCP discussed exercise with them. This number is significantly higher than the rates we saw documented by providers using the .EIM smart phrase, which hovered around only 4 to 20%. Assuming patients are recalling their visits correctly, this discrepancy suggests that providers are underutilizing the smart phrase and essentially not getting credit for their exercise discussions with patients. Okay, I presented quite a bit of information, so let's take a minute to summarize everything. Overall, the integration of EIM at UC San Diego Health has been successful so far. We have worked hard to ensure that the processes are as efficient and seamless as possible to ensure long-term sustainability. In terms of our primary re-aim outcomes, we have seen that reach and adoption are high. The implementation of components has been variable, primarily due to the low uptake of providers using the smart phrase to document their physical activity discussions with patients. Over the next 4 years, we will evaluate the effectiveness and maintenance of EIM. At the beginning of this presentation, I listed many of the people who have helped to make this project successful. At the heart of this project is a collaboration between researchers and clinicians who often have different perspectives, concerns, and goals. This slide lists some of the key ingredients to successfully navigating such a collaboration. Although we have had some bumps along the way, in the end, I have no doubt that our goals and the methods and processes we are using to accomplish them are markedly better because of the multiple perspectives that have come to the table with energy and passion for making a difference in the lives of our patients. The next steps of this project are to implement EIM in the remaining 2 primary care clinics that we initially proposed, and then to implement it in additional clinics within the UC San Diego Health System, including the Student Health Services on campus, which recently joined our EPIC platform. In years 3 through 5 of the grant, we will have enough follow-up visits to examine potential changes in PAVS data and generate potential cost-effectiveness models of EIM. In the next few slides, I will demonstrate how we plan to build cost-effectiveness models. We will estimate the total cost of delivering EIM, including upfront costs such as EMR programming builds and ongoing costs of delivering it, including each involved healthcare provider's time. We will also estimate the total annual direct medical expenditures per person, including both payer costs and out-of-pocket spending. The reference here was used to estimate these costs in order to build the simulation model demonstrated on the next few slides. For the simulation model, we used published literature to estimate the annual healthcare costs and health utilities of patients doing no physical activity, some physical activity, or meeting physical activity guidelines. We used published population health data to estimate the percentages of patients in each of these 3 physical activity categories at baseline. We overestimated the cost per person of delivering EIM relative to no additional cost of not delivering it during a routine primary care visit. Finally, we estimated the mean patient age to be 50 to represent the mean age of patients in the primary care clinics we serve. This slide shows you an overview of the entire simulation model. I'll zoom in on the branches in the next few slides, but overall, the top main branch symbolizes implementing EIM and the lower main branch symbolizes not implementing EIM. We used a time horizon of 5 years to align with the length of my current funding cycle. Within each small branch, we're examining the probabilities of patients' PAVS data over time, either increasing, decreasing, or staying relatively the same. We use the broad categories of sedentary, meaning 0 minutes of physical activity, insufficient physical activity, meaning more than 0, but less than 150 minutes per week, or sufficient physical activity, meaning meeting guidelines of 150 minutes or more per week. For this simulation, we assumed very small probabilities of patients moving from one physical activity category to another over time, since this is a low-touch intervention, and we know that moving the needle of physical activity behavior change on a population level is inherently challenging. Nevertheless, even though brief advice has a small effect on increasing physical activity, that small effect can make a significant difference if applied to a large population of patients. However, these assumptions may be gross underestimates according to published literature in this area. For example, a 2012 meta-analysis published in the British Medical Journal found that brief primary care interventions could result in one additional person achieving guidelines for each 12 patients exposed to the intervention, with the effect being maintained over 12 months. The primary outcome of our simulation was net health benefit expressed in quality adjusted life years, or QALYs. Despite our conservative estimates, EIM was favored in our simulation model, which estimated a cost of $21,468 per 3.84 QALYs for EIM, relative to $21,164 per 3.83 QALYs with no EIM. In other words, an estimated incremental cost of $303.97 for EIM results in an incremental benefit of 0.009 QALYs. These results align with the previously stated expectation that even small effects can make significant differences when applied to large populations of patients. This graph depicts this simulation, which resulted in an incremental cost effectiveness ratio, or ICER, of $32,925 relative to a commonly used willingness to pay threshold of $50,000 per QALY. We look forward to building models based on the actual PAVS data and healthcare costs observed within our health system to determine whether the simulation model is supported. Finally, let's briefly review the limitations of the project and the future directions. Limitations are primarily related to the setting. As most people are keenly aware of, San Diego is a unique place, and results coming from here may not always apply to other places with different cultures and climates. Similarly, UC San Diego Health is an academic medical center with a culture of data collection, monitoring, and quality improvement processes. A project like this may be difficult to pull off in a different type of institution. Finally, 3 of our clinics exist within the Department of Family Medicine and Public Health, so we tend to have a pre-existing focus on health and wellness topics. Our providers may have already been talking to their patients about exercise long before EIM came to town. Our goals for the future are focused on dissemination and implementation in other systems, including other UC health systems across the state of California, as well as other healthcare systems in the San Diego region. We will be creating toolkits to better assist other health systems and enable them to replicate our methods and materials. Thank you very much again for asking me to speak today. I appreciate your attention and welcome any questions you may have.
Thank you, Sarah. What a great presentation. I mean, a very complex study, but much needed for sure. And I'm very excited to hear that you are going to include cost effectiveness in your study as you move forward. I think that's much needed as well. We do have some time for questions. So I'll offer up a few questions to Sarah here. The first is, Sarah, what are the physicians' perceptions about how this study is going so far?
So far, the physicians have had a generally very positive attitude about how it's going so far. As we roll out at each clinic, we have noticed that there's some pushback initially when we arrive. Providers feel like they're already overwhelmed with things to do, and this seems like just one other thing on their list to do. And so that we've found that to be the case with maybe 1 or 2 providers at each clinic, although most providers have just welcomed it from the start. But as they've all tried it, even the naysayers at the beginning have found that they say it actually saves them time, because they say they were talking about exercise anyway, and now having a simple way to do it and document it and refer on to someone else to have a broader discussion has been very helpful and actually has saved them time. So overall, they've had a very positive reaction.
Did you have to do any special training with the physicians or the clinic staff around asking patients to report their exercise?
Yes, we did. So we initially tried to do this on a clinic-wide level, just with everyone coming to one meeting, but we found that when we did that, we always had some people who couldn't make it, and some clinics just had very low turnout at meetings. So what I did is I just started going to those clinics myself and spending time there and meeting one-on-one with each of the providers, training them how to, for the MAs, how to ask those questions, the PAVS questions, or record them in the EMR. For providers, training them how to do a brief, 30-second discussion, if that's all they have time for, about how to talk about physical activity with their patients. And they all found those very helpful. Many providers, especially some of the PCPs in family medicine and public health, already felt very confident in how to talk with their patients about exercise. But for those who didn't, just kind of going over some strategies to briefly bring up how to talk about exercise with patients without, having to go into a very lengthy discussion, which is kind of their fear, is that if they broach the topic, that will take up the rest of the visit. So many of them found that very helpful, how to bring it up, and if patients start to talk quite a bit about it, then they have now these tools to refer them to the manual or to the health coaching service.
Yeah, that makes total sense. It was interesting to hear that you included patients as you were planning your study, and now that you're also following up and getting some patient reported information about their experiences in the study. Has any of the information that the patients have provided, has any of it surprised you or provided really interesting insights from the patient perspective?
Yeah, definitely. I think that the most surprising and also most encouraging was the recent data that we collected, asking patients if they recalled each of these EIM components happening in their visit. And frankly, I was quite surprised at the high rates that they did recall these things happening. It's really encouraging that we're making an impact, that we're doing this, and the patients are not just kind of filling out the questionnaires without even thinking about it, or kind of sleeping through the visit. They're actually hearing it, and so hearing that was helpful for us. But also some data I did not present on the slides that we do have is some actual feedback, qualitative feedback that we included on the survey, that we got some pointers from patients about how to improve it even more. They said that, for instance, they didn't feel that they knew what the term exercise is medicine was. They had been taught, their physician talked with them about exercise, but they were not familiar with the term. And although that's not super important to get the message across, I think we could do a better job kind of packaging it and telling them that we're going to be, including the exercise as medicine program at every visit, from now and forever till forevermore, and just raising awareness that that's a whole package for the patients might be helpful. So they kind of identified the components that didn't recognize it as a whole program, and so I think we can do a better job of that in the future.
Did you collect any information about the activities that the patients chose to do? Do you have any sense of, I know some of this was happening right when the pandemic hit. Are people doing walking mostly, or do you have any sense of that?
Yeah, we don't have that from the paths, unfortunately, because it's not specific to what they're doing. We just know from really anecdotally what providers are telling us that patients are telling them that they're doing, and that patients are asking them about during the pandemic. So saying, for instance, I usually go to the gym, or I usually walk outside and I don't feel safe doing that. What could I do inside? So I guess anecdotally, my sense is that, we're in San Diego. A lot of people are exercising outdoors, but surprisingly, we do have a fair amount of people who go to gyms as well. Even, the weather is pretty great year round. I think especially for our older populations, a lot of them go to gyms where they, have supervision, support, and so they're especially unsure about what to do because they really don't feel safe going outside and walking, given that they're at higher risk. So that's going to be a challenge to see, how our rates for our older populations change during this pandemic. But we don't have any recorded data of the activities that you're inquiring about.
Okay, so for those of you listening who maybe aren't familiar with implementation science, can you just speak briefly to how you track and report the changes that you're seeing? You talked about cycles where you're evaluating and moving things around a little bit. How do you track and report those types of changes within the study?
Yeah, that's a great question. It's an ongoing challenge because sometimes things happen rapidly and you have to really remember to document those things so that later when you for instance, look at that EMR data, you're able to piece things together and say, oh yeah, the rates decreased here. Oh, well, that's because that was when the questionnaire wasn't being fired, it wasn't firing in Epic. So it's really, you have to be very diligent about documenting changes that as you see them happening, and then trying to connect the dots with different things that may be going on in the clinics, and especially tracking those different adaptations to fit within the workflow of the different clinics. For instance, the check-in process where patients are either completing the PAVs on paper and having it recorded, or they're completing e-check-in, or the MA is asking the questions aloud. We've shown, as I showed in the data here, that really makes a difference in the percentage of PAVs data that is recorded. And so if we make changes to the workflow, it's very important that we systematically track those. And so later, whenever we're writing our paper that we'll submit for publication, we can provide documentation of how we made changes and how that resulted and affected our outcomes, because that's important whenever you're making a toolkit then for passing it on to another system, is to show how, if you tweak these different things, you might have different outcomes. But you ultimately always want to make sure that at the end of the day, you're doing what's best for the workflow of the clinic. If you have an idea that, you can change something drastically because it sounds like it'd be really cool and very efficient, but it's not the same as they do, complete other tasks within the existing workflow, it's not going to work. They won't do it. So you really have to make sure that your program aligns with the way things are already done.
That makes total sense. I can imagine, some ideas are great, but implementing them is a different issue. So we have time for a couple more questions. We have time for two more. One is, what does the health coach do within your study design? Like what information does that person cover? How many visits, or is it just one call? Like, what is the role of the health coach?
Yeah, so that's actually one thing that we have made adaptations to over time as well. We initially decided on only one 15-minute visit, and after we implemented that for a while, we had so many patients asking for an additional visit for a follow-up that we decided to change our protocol and make it up to 2 visits. We don't mandate it, but we offer it, and most patients take us up on that. So the things that the health coaches cover, really, they vary quite a bit depending on where a patient already is. So they really very quickly figure out what stage of change that patient is in. And if they're early in the process, then they're going to spend the time, identifying what are the potential reasons that you would want to exercise. What are your motivations? What are the barriers you might run into, and how could you think about overcoming them? If a patient is already doing some, but they're having trouble, getting further along, then maybe goal setting and coming up with some benchmarks. And a lot of times, honestly, we get referrals too from people who are already meeting guidelines, and they want to refine their exercise regimen. So we are able to do that as well. So really, our health coaches are very adaptable. They're initially, when they started, they told me, oh no, 15 minutes is not enough. There's no way I can get through a visit. But now that they have the process down, they said it's exactly 15 minutes. They're able to quickly identify where the patient is, meet them there, and figure out what's the next step in helping them to move forward.
Great. Okay, last question for Sarah. What are the biggest lessons you've learned at this point? Your study's not done yet, but it didn't just start. So what's the biggest lesson you've learned so far?
It's a great question. I've learned so many, but I would definitely say that the collaboration and teamwork is just so important. Without the physician champions, this just wouldn't happen. Without Dr. Kallenberg being kind of my partner in crime, he's very invested in this project, and he's the one I mentioned earlier that's the director of the medical clinic and also the division chief for family medicine, and he has really advocated for this to move forward. And sometimes you really need a person like that who has a strong voice and who has an important title to help you move forward. So really, making sure that you are collaborating with the right people and that they're invested and that you maintain a really positive relationship with them, because that's the way to get these things to move forward. There are so many competing initiatives out there. So many people want to get, new initiatives in, new questionnaires, new programs, and to have yours stand out and to move forward, you really need to work with the people who are on the ground and have a say and have a voice in this. And so I think that I've just learned to really not come in and try to do it all myself, but really to say, okay, this is what I can offer, and now I need others to really put their ideas forward and help me to move this process forward.
Thank you so much, Sarah. That was really a great presentation. We really appreciate you sharing your study with us and your time. I'm going to ask Sarah to advance her slide. I want to make folks aware of something new that's happening. The EIM Research Learning Collaborative is a new program at ACSM. Our goal is to bring together early, mid, and late career scientists to discuss different aspects of conducting research related to the integration of physical activity in health systems. So similar to the type of research that Sarah shared with us today. We hope to host presentations, manuscript reviews, discussion sessions, etc., that will serve as learning sessions for people looking to gain expertise in this area. If you'd like to learn more, we would love for you to join our listserv, and you can do that by sending an email to Mark Stoutenberg. His email is there at the bottom of the slide. So please consider joining us for that. And then I'll ask Sarah to advance her slide once more. The final thing I wanted to tell you all about was the ACSM 2020 virtual experience. As you know, unfortunately, we had to cancel the annual meeting in San Francisco this year, but we didn't want to go a whole year without providing some outstanding scientific content to our members. So starting in June, we are going to have some of the content that would have been presented at the ACSM 2020 annual meeting presented in a virtual experience. We'll start releasing content around June 17th. This will all be done, it will be recorded content that you can watch on demand when it's convenient for you. But basically, I'm just encouraging everyone to visit the acsm.org website starting soon, next week, and throughout the month of June, as we will continue to release content and new science for you all to enjoy and share. Finally, this concludes our Brown Bag series for the 2019-2020 academic year. We want to thank everyone who participated this year. We know the spring has been very challenging, so we also want to say, a special congratulations to those of you who graduated this spring. So at this point, we are going to say thank you once again. We'll be back in September to resume the series, and thank you again to Sarah, and at this point, we'll end the webinar.